Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's webinar. Let's welcome our guest with great honor, none other than Professor Dr. Madhulata Alexander ma'am. And let me share some of the achievement of ma'am. Ma'am has done MBBS, MD in obstetric and gynecology, and she is professor at Osmania Medical College, Hyderabad. And today she is going to discuss on a very important topic, that is postpartum contraception. To know more about this topic, I would like to invite ma'am. Ma'am, stage is yours. You can start this. And yes, ma'am.
Thank you, Bharat. Now, this topic, postpartum contraception, is very relevant and very important, and I'm very glad you have selected this topic for discussion. Uh, okay, what is the importance or what are the benefits of postpartum family planning? Okay, postpartum, that is after you deliver. Family planning can avert more than 30% of maternal deaths. By adopting appropriate family planning measures, we can avoid or avert 30% of maternal deaths and 10% of child mortality. If the couple space their pregnancies more than 2 years apart, that is, after delivery, the second child should be planned after 2 years. Closely spaced pregnancies, inter-pregnancy interval less than 12 months, increase adverse outcomes like low birth weights, small for gestational age, and preterm pregnancy. When do you do this postpartum family planning, PPFD? When is the timing? It can be done immediately within 10 minutes of delivery. This is called post placental. As soon as the placenta is delivered, we adopt this family planning method. What we do it is for the PPIUCD, what we in government, I work in the public sector in the government of Telangana, and we are following this very commonly. That is, as soon as the baby is born, after the placenta is out, we are placing this IUCD. You can also practice family planning immediate postpartum, that is up to 48 hours. This IUCD can be inserted. And postpartum is initial 6 weeks after delivery. That is, you can do it after 6 weeks. And extended postpartum is up to 1 year. Now, most family planning methods extend up to 1 year. Now, after delivery, we can insert the IUCD or implants, that is the progesterone only implants. But this implants in our country, has just started coming into thing. We usually do these implants only after 6 weeks in India at least. What are the various birth control methods? What are the postpartum birth control methods? I'll just run through it. It's very simple. The condom, the female condom, oral contraception. Oral contraception should be started preferably after 6 months because of the problem of embolism, of the clot formation. If the patient is not breastfeeding, we can start after 3 weeks or preferably after 3 months. But what is recommended is better to start oral contraception with the estrogen component after 6 months. Hormonal rings also can be used, but as you know, they also have estrogen component. They should be done only after 3 months. The IUCD can be done immediately after delivery, or if you miss that 48 hours, you can do it after 1 month. Injections also are usually done only after 6 weeks, and surgical sterilization can be done immediately after delivery. Implants. Implants are the progesterone in implants, which are very popular in the West. They have just come into India, and many people are using it. I believe after delivery it can be used, but generally we use these progesterone implants only after 6 weeks. Coitus interruptus, calendar rhythm method, vaginal douche, contraceptive patch, and diaphragm tabs can also be used. Now, if you compare the effectiveness coming from the least effective, that is the withdrawal method or the fertility awareness based methods, or the spermicide, which are least effective, the more common or the more effective ones are the ones at the top: the implants, the female sterilization, the vasectomy, and the IUD. So IUD has a very honorable position on the top of the list, which that's why the government is trying to push this kind of contraception in India. Now, what this is a very good slide given by the government of India about when exactly you start the postpartum contraceptive methods. Now, at birth, if you see at birth, what all can you do? You can do the male sterilization, or the female sterilization at birth, condoms and spermicides, and the lactational amenorrhea method. This can be done in the first 6 months. I'll come to it later. And the progesterone only methods. Progesterone only methods in non breastfeeding women can be done at the time of birth. But if the woman is breastfeeding, we recommend that you do it after 6 weeks. That is the implants, the injections, etc. Combined hormone methods, definitely it is only after 6 months. But if the patient is not breastfeeding, some books say we can start at 3 weeks. But we as obstetricians, we usually start only after 3 to 6 months. Now, what is lactational amenorrhea method? It can be started immediately, as you know. It can be given to a person who's exclusively breastfeeding and immediately after birth. IUD also can be inserted immediately, post placental. Female sterilization and male sterilization can be done. Of course, male can be done anytime, female within 7 days. And the condom as soon as sex is resumed. And fertility awareness. When you do this, that some people are very fond of using this method, you must tell them that if you get regular cycles, at least three, then you can start following this method. Combined COCs only 6 months after childbirth. Progesterone only methods. Usually we recommend after 6 weeks. Or if the patient is not breastfeeding, you can give the injectables or the implants immediately after childbirth. Vasectomy can be done anytime. Now, the WHO has given eligibility criteria because they call the MEC 1, 2, 3, 4. One is category 1, there is no restrictions to use. Now, what is this? Is category 1 like something like female sterilization or male sterilization? And also the copper IUD also can be under category 1. But once you start using the LNG IUS, it becomes category 2. That is, the advantages generally outweigh the risks. Category 3 is the risks outweigh the advantage. Category 4 is no. It's a definite no, no. Now, the MEC criteria has developed depending on the government has developed it for the World WHO. There are recommendations based on who can use it, and there are many recommendations, and it has been developed through systematic consensus through across many countries. There's a nice wheel. Actually, if you see that wheel, anybody using it, like you can see the patient has delivered or she has not, or she has health conditions, you just move that wheel and it can zero in on what method can be used. It can be used in the field to tell the patient what options they have for contraception. Lab. Lactational amenorrhea method it's a very simple method. It is being very much popularized by the government of India. The main thing is you have three criteria. That is, the mother should only be breastfeeding. The patient should not have menstrual bleeding. The patient should be exclusively amenorrheic. And the baby is 6 months or less. Now, if any one of these criteria is not met, you have to transition to another method of contraception. This is very effective, and the government of India claims that it's got very good results. Now, supposing this unplanned pregnancy, the woman presents to you, what do you do? Like for a simple example, a 25-year-old woman has come. She has delivered 11 months ago. She is not on any contraception. She is having amenorrhea for 2 months. She has had only 2 periods in delivery. What do you do? She needs contraceptive advice. She has come to you. What do you do? Now, this is a very good. I've got this from the FIGO guidelines. That is the government of India has issued nice family planning guidelines. They have given this checklist. So they've given a checklist. Did your something like this? Anybody can go through these checklists even in the periphery. Did your last monthly bleeding last within the last 7 days? Or have you abstained from sexual intercourse? Have you been using a reliable contraception? Have you had a baby in the last 4 weeks? Okay, all this criteria you go through, the ANM goes through it. And if the client has answered no to all the questions, pregnancy cannot be ruled out. Then you have to again check out ruling pregnancy by other means. If she answered yes to at least one of the questions, you can be reasonably sure that she is not pregnant. Now we come to our topic today, that's postpartum contraception. What are the options? The mother is asking you, I am breastfeeding. What are the options do I have so that I don't conceive? Very commonly now is being used the non-hormonal method of the centrochromon. I'll come to it a little later. It is very popular in Tamil Nadu and they claim very good results. Main thing, it is not hormones. It's a SERM or the estrogen receptor modulator, and it is very good. progesterone only hormonal methods, and the conventional hormonal methods. Now, what ACOG, as I told you, we should not use the combined contraception below 6 weeks, and better to delay the COCs, or the combined contraception, oral pills having estrogen, even if it's low dose, till after 6 months. Now, what is this the COC, the combined oral contraceptives? That is why we don't use it is because of the thromboembolic risk. Estrogen containing oral pills are contraindicated in the first 6 months in breastfeeding women, definitely. Now, if a woman is not breastfeeding, you can start COCs by a third week, but it is recommended at least wait for 3 months. Women who are not breastfeeding, remember, they start ovulating by 45 days. So she should be ready with some kind of contraception by then. For breastfeeding women, you have to start birth control women at least by 6 weeks. And we all know menstruation and ovulation are unpredictable in breastfeeding women, and therefore the timing of the initiation of contraception is very important. Now, in this context, we come to the postpartum IUCD, which has got excellent results. It is very good because it's a long term, LARC, long term reversible contraceptive method. It's an alternative to tubectomy for some couples. And it's very easily accessible. Now, main thing is it can be put in the peripheries. After delivery, even the midwife can put it from the vagina. And if she had a section, anybody can be doing it at time of section. So this is a very safe answer to all our questions. Now, IUCD, who should not use? Now, these are the criteria for WHO category 4, which should be done in the non-pregnant state. That the patient who is not pregnant, who has come for contraceptive advice, these conditions you should not be using. It can be extended to the parturient also. Is she pregnant? Has unexplained bleeding, concurrent infection, distorted cavity, trophoblastic disease? All these people you should not be using IUCDs. Same thing happens in after delivery also. Now, what about category 3? That is the risks outweigh the benefits. They are not recommended for insertion if the woman has having AIDS, she's having HIV positive, but she's not on antiretroviral therapy, or she doesn't have any access to a care. Don't give her a copper T. And a high individual who has a high risk of chlamydia and gonococcal, who has a high risk of sexually transmitted diseases or ovarian cancer or benign trophoblastic disease, do not give it because here the risks outweigh the benefits. What about the MEC and the postpartum IUCD? Now, when do you do? Category 4 is when you do not give. It is dangerous. You should not be putting the IUCD. That is immediately after septic abortion or puerperal sepsis, or sometimes in the unresolved postpartum hemorrhage. Do not give the IUCD, postpartum IUCD. Category 3 is, as I told you, the risks outweigh the benefit. After 48 hours, do not insert the IUCD. If you have missed that, wait for 4 weeks and then only insert it. And also, prolonged rupture of membranes more than 18 hours, you should not be putting the IUCD, although this is not mentioned in the criteria. Category 2, that is the benefits outweigh the risks and no conditions. And category 1 is it comes under it. Immediate post placental or postpartum or more than 4 weeks. Category 1, the copper T comes in category 1, but surprisingly, the LNG IUS or the Mirena comes in category 2. What are the most likely precautions? As I told you, do not, when the bleeding is not resolved, do not put the IUCD. When there's infection or chorioamnionitis or rupture of membranes more than 18 hours, or recent purulent cervicitis. In these conditions, there are checklists which are given by the USAID and Access. You can go through it and just check it out before doing it. What are the progesterone only pills? These are very good contraceptives, but the only thing is it is expensive and has to be taken at the same time every day, and the window that they have is very less. Unlike LNG, when you take the combined oral contraceptive, even if you miss a pill for 12 hours, you can take two at the next time. But here, even if you miss for 3 hours, you must use alternative contraception for the next 2 days. How does it work? By ovulating, by inhibiting the ovulation or thickening of the cervical mucus. You have to give it continuously over 28 days. There is no pill-free interval. It's marketed under the Cerazette. It all does not have estrogen. It's only progesterone. It does not affect milk quantity and quality. It has not have affect any growth rate of a newborn, because I don't think any mother will allow you to take this kind of drug if it had any effect on the growth of her baby. It is a bleeding profile, but sometimes you may have some kind of spotting. It's generally acceptable in the majority, and there's no change in body weight, which is very important for all women. Women will never accept any contraception in which they will gain weight. Drosperidone only pill is another pill which is being used. It comes under fourth generation progesterone, but what's happening is it is just started being available in India, and these pills can be used if the mother is breastfeeding of any age, or who had an abortion, or patient who smokes cigarettes, because cigarettes for smoking COCs are contraindicated, have anemia and varicose veins. You can use this drospiridone or the fourth generation progesterone only pills. Now, this is the MEC, the ring that I showed you, which is very used. It can be used by anybody. It's a wheel, and it is given to all our ANMs. They can easily just move it, see the patient age, all this, and she can check out what are the options she can give her patients. Centroman or Chaya is being propagated by the government of India. It is non-hormonal, non-steroidal. It is tissue selective estrogenic, or it has anti-estrogenic effects. It suppresses the estrogen reflex receptors in the reproductive organs, leading on to contraception, but stimulates those of other organs like bones. So it is advantageous. The dose is very simple: 30 milligrams twice weekly for 3 months, then weekly. Breastfeeding, you can continue. And it causes less bleeding during the monthly period, and also makes the interval between two menstrual cycles regular. It's good for anemic patients. Government of Tamil Nadu has popularized this, and many patients are using this in Tamil Nadu. It has not yet come to the state I am in, and it is there, but it's not yet popularized so much as Tamil Nadu. What about sterilization? This comes under MEC 1. It's very convenient. And the only problem is it's you have to counsel the patient very well, because it is a permanent method. And as you, in the West, I believe, if you want to take consent for sterilization, at least 2 weeks before delivery, you must already take it in writing. But in India, it's not that. At least before delivery or before section, we take the consent for sterilization after normal delivery, or before section we take it, and again before doing it we always counter check with the patient, because the problems are the chances of regret. Sometimes patient may have a change of partner which was unexpected at the time of delivery, greater chance of failure, because our postnatal, if you do the sterilization, there is more chance of failure. And there's something definitely called post ligation syndrome. After doing it, patients have more bleeding, they have back pains, headaches. It has been documented, although there's no scientific reasons. Male involvement has to be there. Decision has to be made at the household level, and it has to be a supportive environment throughout the community. It has to be done. Now, injectable hormonal contraceptives is gaining popularity in the state where I'm in. Many people are accepting it. Okay, it's called DMPA or NETIN. This may reduce endometrial cancer, fibroids, frequency of sickle cell crisis. It's easy, effective. It's also very private, and no effect of breastfeeding. The only problem with this is it's known as Depo-Provera is used. The only problem is given as 150 mg every 3 months. Given you shake it up and give it to the upper arm or buttocks. The main thing is the menstrual changes. There is spotting, which is patients in India are not able to accept. Okay, so they don't like it. That is why, that's the main reason why they stop taking this contraception. Some patients repeat headache, dizziness, or change in delay to return to fertility 10 to 18 months later. Another thing, it does not protect against the sexually transmitted diseases or HIV. Then long acting reversal contraception after giving birth. You can give oral contraceptives. They are not recommended immediately, as I told you. IUCD and LNG IUS can be given after birth also. What about disease? Usually, CHC does increases the risk of cardiovascular diseases, myocardial infarction, stroke, and thromboembolism. POP, that is progesterone only hormones, do not increase the risks. Injectable progestins are contraindicated only in severe or labile. If the patient's BP is not getting controlled, do not use these progestins. Now, I just run through a few cases just to as a completion sake, where it will make this lecture more relevant to us. Now, a 25-year-old gravid 2 suffers from DVT of the left popliteal vein at 34 weeks. She is managed with heparin and on low molecular weight heparin. She has had a full term normal delivery at 40 weeks. She wants to avoid pregnancy henceforth. What would you advise her? Probably the best thing, I mean, as we know, we do not know what's best for her. The choices given to her will be she can undergo tubectomy, or definitely you will not give this patient uh, oral contraceptives with the estrogen component. Okay, even progesterone pill can be started, but at a later date. The second case is about uh, about hypertensive cases. What would you do for this case? She delivered 2 weeks ago, eclampsia, induction of labor, and forceps 2 weeks ago. What would you do? And she's found to be hypertensive. In hypertensive cases, and now she delivered 2 weeks ago, so there are not many options left to you. You ask her to come back. But in these kind of patients, the combined pills are contraindicated. Okay, and ask her first to get her BP checked up, and after when she comes back, you have to decide and advise her what to do. The third case is a woman with diabetes. She's 35 year old, one child. She has type 2 diabetes on insulin therapy. She reports 8 months after delivery. She wants to plan pregnancy after 1 year. What are the various options? Probably the best advice you would give her is first control your diabetes. Let your HbA1c be under control. And also, as you know, diabetes is progressive. You advise her that risk of don't postpone your pregnancy too late. Okay, 1 year is enough. But unless your diabetes is under control, do not try for a baby. All the options are available to her. Only thing is COCs may cause some kind of problem with the sugars, but we have to be careful when you give it. Fourth case is a HIV positive couple. They are reporting at 10 weeks. They're just pregnant. The wife is put on ART and she goes to pregnancy. She has a vaginal birth at term. How do you counsel this couple? Even throughout pregnancy, you must tell them that they must use condom protection, and a dual method of contraception is necessary. Even if you put a PPIUCD or whatever you're using for the patient, you must always tell them to use a condom also. The fifth case is a 22-year-old reports to the postnatal clinic. She has delivered a week ago at her home. She's very pale. She's mildly breathless and has fever. She recovers with an RBC transfusion and she has parenteral iron therapy. What would you do? The first thing is you build up her hemoglobin. They said she has recovered, so she's okay. You call her back after 6 weeks, re-evaluate her, and give her the options like either copper T or she wants a DNPA, whatever she wants, you have to give it. The sixth case is a case who had a vaginal delivery 2 months ago. She was diagnosed to have SLE. SLE is very common. Like the place where I work in, we work in a government hospital. We get a lot of referred SLE cases, and you'll be surprised to know that SLE is much more common than what is reported. During her ANC, and the problems were taken care of in one tertiary center. Now she has come for contraceptive advice. Now, what are the choices and duration? Now, main thing is the clinical history. Take her history. Does she have the APLA? Is she positive or absent for APLA? What about her current disease activity and the patient's age, her reproductive history and desires, religious and cultural factors? All these should be taken in account before you advise her. Okay. Now these chart, what I put up this chart specifically is they're easily available given by the government of India. Okay. Now this I've taken this specifically for SLE. So if this patient is got, if she is positive or unknown for APLA, then you can see what all the options that she has: the copper T, the LNG IUD, the implant or the implants, DMPA, the progesterone only pill, and the combined pill. Now, all these they've given you categories. All these 1, 2, 3, 4 are the MEC categories. So you can probably take a call, put this chart in front of you, and take a call. And there's a trial called Selena trial, that safety of estrogens in lupus erythematosus trial going on. And these are recommendations based on it. And if the patient is stable, if she's APLA negative, then you can think of combined hormonal contraceptives. Why we go on saying is patients are very comfortable taking it. So they will, whatever method you advise, they will come back to this combined pills. Another one thing I would like to conclude is you have to integrate. It's not only in the antenatal period. When a patient comes to you pregnantly, you have to go on sensitizing her to the possibility of family planning methods. Okay, in the antenatal period, both her and her partner, labor and delivery, including pre-discharge, again sensitize her. Again, when she comes postnatal checkup and immunization. So it should not be considered only a vertical program, but rather integral part of everything. Everybody, whenever she comes to a checkpoint, you must be advising her about the benefits of family planning, and it's a comprehensive care. Okay. Something called breeding contraception. That is, when a woman comes to you for contraception, do not send her off without any contraception. Better to start a contraception even if she's not immediately in the post-menstrual phase. So what we do is, if she has possibility of being pregnant or she had some kind of unprotected sex, you advise her what to do and give her the contraceptive method, what she should be taken. Let her not come back to you for again restarting it because you have lost an opportunity. Okay? The take home message is, unmet need is the highest in the first year post delivery. So be mindful of this. In spite, 95% of ladies, you ask them, they don't want another baby, but they are not able to deal with it. Postpartum period is unique, adding more reasons not using contraception. Because suppose a woman is delivered, she may not want to use contraception. She doesn't want to give the perfect thing to her baby. She wants to give unadulterated breast milk. So this is the time for you to advise her. Spacing for 2 years at least improves fetal and maternal outcome. And also the woman, if she does not want to, if she has come to you with unprotected sex, give her emergency contraceptive pills, and this will help the woman. And also in special situations, it can help. Thank you. Yeah, thank you.
Thank you so much, ma'am, for taking out your important time and sharing your knowledge on this topic, ma'am. I definitely think this session knowledge is going to help all the participants who have joined this session. As I can see, ma'am, we have received some question. With all your permission, shall we take these questions?
Yeah, sure. Go ahead.
Yes, ma'am. I can see the first question is from Dr. Archana, and she is asking, like, ma'am, what are the recommended methods for contraception during the immediate postpartum period, and how do they vary based on breastfeeding status?
Yeah. The immediate postpartum period, it can be temporary or permanent. Now, I assume the patient has just delivered. Okay. So if she has just delivered, you can give up. The first thing is, you can give a IUCD. As I said, postpartum IUCD is very good. It can be given. And in in a patient, the other things can be is implants and injections. That's the progesterone only, intradermal implants. But we in our country are not doing it. What is recommended is, if the patient is not breastfeeding, then you can do progesterone only pills after 6 weeks. Okay, after 3 to 6 weeks, you can do these implants and injections. But if she is breastfeeding, you better to postpone it. See, if you look at the chart which I showed you, they have given that you can give these implants and injections at the time of delivery. It's given very clearly, but we do not do it. We wait for 6 weeks because progesterone also may cause some effect, some kind of thromboembolism. So, what I would suggest is, at delivery, the best thing to do would be to put the IUCD. Wait for 6 weeks, then start the progesterone only pills, even if she is breastfeeding. If she is breastfeeding, you can delay the COCs up to 6 months.
Thank you so much, ma'am, for answering, ma'am. I hope that doctor has received his answer. Moving forward, I can see another question, ma'am. Like, what is the role of long-acting reversible contraception, that is LARC, in reducing unintended pregnancy postpartum, and what are the barriers to access?
See, the main thing is the long-acting reversible one is the implants or the copper T or whatever. The main thing is the patient should be sensitized before delivery, and depending on what she wants, we can give her the choice. See, I told you I work in a public sector, so before delivery we go on sensitizing the patient to this PPIUCD. It has got certain acceptations, but one person in that person's family doesn't accept it, then the whole family will not accept it. Okay, the main thing is, even if she does not accept that kind of contraception at the time of delivery, call her back. After 6 weeks, again call her back. Even if she does not, the patient, if she's not breastfeeding, she can ovulate within a month. So, but after 21 days, she must be having some kind of contraception. At least let her know. You can use barrier contraception, or if she can afford it, after 6 weeks, we start off progesterone only pills if she is breastfeeding.
Thank you so much, ma'am, for answering, ma'am. Dr. Archana is writing. Thank you so much for your answer. I hope sir, she is really like learning from this session, ma'am. Thank you so much, ma'am. As I can see, there is no more further question. I hope, ma'am, you have done justice to this topic, ma'am. As there is no more further question, with all your permission, shall we conclude this session, ma'am?
Thank you. Thank you for us.
Thank you so
Okay.
much, ma'am, and we would like to see you in future also with different topic. Till then, take care of yourself, ma'am. Thank you so much for joining.